and health. And, I mainly practice in the outpatient settings, and I've been doing endocrinology for more than 10 years now. So, and I'm thank you for giving me this opportunity, and I'm glad to be here, Priyanka.
Thank you so much. So can you tell us a little bit about the process of you becoming an endocrinologist, and maybe tell the audience like why you chose this field specifically?
So I did my medical school back in India, and then when I came here, I was doing my master's in public health, and during that process, I was a research assistant with an endocrinologist in the hospital at University of Iowa. And as a part of the research assistant, I was contributing to basic endocrinology research. And in that process, I was interested in the field. I asked him if I could shadow him, as you do. And I started going into the hospital with rounding with him, etc. And then I realized the endocrine system is intricate. It's pretty much all the hormones control each and every part of our body. And that's how, I got interested in endocrinology, and that's how I, decided to pursue that field.
So many people here will probably know about like the roles of the various like body systems, like the cardiovascular system or the respiratory system. But can you explain the role of the endocrine system and its importance in like our overall health and well-being?
Yeah, sure. So the endocrine system contains, basically of all the glands in the body. So the common ones that we would know is the thyroid gland, which is located in the neck area, and it controls each and every portion of our, body, directly or indirectly. It will control the heart rate, it controls the muscles, it controls our intestines, it controls the functioning of the brain, etc. So that's the common thyroid gland that we all know. Then we also have the adrenal glands, which are two glands on top of our kidneys. They produce different hormones, and deficiency of those hormones can cause adrenal insufficiency, or excess of those hormones can also cause issues. Then we have the master gland, which is the pituitary gland, which is at the base of the brain, and that is actually controls, it controls the thyroid, the adrenal, and the other glands in the body. And then the other glands also includes, the female and the male genital organs also, which help with the development. The hormones will help with the development as well. So yes, that's pretty much includes endocrinology. And then, of course, not least but not, is the pancreas, which produces insulin, and the deficiency of which can cause diabetes. So that would be also so pancreas could be both endocrine and exocrine, but the endocrine portion is what we take care of.
So you mentioned like hormones a lot. So what are hormones, and like how do they impact like our health?
So there are different types of hormones. So as I said, there's thyroid hormone. Then there is the adrenal glands, which are glands on top of the kidneys. They produce a hormone called cortisol, which is commonly referred to as a stress hormone. Like whenever we have any stressful situation, that level goes up, even normally. And sometimes the adrenal glands either become enlarged, or there is something on the adrenal which will cause it to produce too much of the adrenal cortisol level, which can cause, excessive weight gain and many other symptoms. So that's the cortisol. And then there are some other hormones produced by the adrenal gland. Then the pituitary gland produces certain other hormones like the prolactin, which is the milk hormone that helps in the, lactation period. So these are the different hormones that we generally deal with. Then, there is, of course, estrogen, progesterone, and testosterone. Those are also included in this field as well.
So in this field, what are like some common disorders or conditions that you see in endocrinology in your practice of these?
So the most common is diabetes, and most commonly it is diabetes mellitus type 2, which happens later on in life. That is number one. Then secondly, I would say hypothyroidism, which is underactive thyroid, where the thyroid does not function to its fullest level. Then there is hyperthyroidism, where the thyroid is overactive and it's producing too much thyroid hormones. Then next to the thyroid, there are also small other glands called the parathyroid glands, which control the calcium in the body. So that is another common condition that we see, which it can cause hypercalcemia or high calcium levels, which can be associated with kidney stones and fractures, etc. So these are the common ones. Then we also sometimes see, conditions where the pituitary gland, the master gland, has a little swelling or a lesion there, and that can produce too much of any of the hormones because it's the master gland, so it controls all the hormones. So it could either cause too much of production of one hormone, or it could be multiple hormones, or it can cause deficiency of those hormones. The most common one is increased prolactin production. So some people come in with high prolactin levels because of the pituitary lesion. So these are the common ones that we generally encounter.
So when it comes to like the hormonal imbalances that you mentioned, what are some early signs that people can see when they have hormonal imbalances?
So it depends upon which hormone is being affected. So, if the thyroid is being affected and if it is causing underactive thyroid, then some of the common symptoms are feeling tired, constipation, dry skin, unintentional weight gain, or difficulty losing weight, non-specific joint aches, joint pains. It also depends upon the age of the patient and, how severely it is impaired. So that would be for underactive thyroid, which is one of the common conditions. Overactive thyroid is the opposite. It causes all hyperactive symptoms like racing of the heart, feeling anxious, jittery, unintentional weight loss. So that would fall into the thyroid part. Then for the prolactin, if the pituitary gland is producing too much prolactin, and for females, it can cause milky discharge from the breast area, it can cause irregular menstrual periods, etc. Then, and for diabetes, some of the common symptoms of diabetes are increased urination, increased thirst, and unintentional weight loss. So, it is polyuria, which means too much production of urine. Polydipsia, which means we drink a lot of water because we feel very thirsty, and polyphagia, we eat as much as well because we feel very hungry. So those are the 3 P's that go along with diabetes. So these are the 3 common ones that, 3-4 common ones that we see.
So what are like some potential causes of these like hormonal imbalances, and do they differ between men and women by any chance?
Yeah, so for the thyroid is more common in females than males. The thyroid disorders, they are hereditary. They have a hereditary predisposition, and any environmental triggers or factors can increase the chances of showing the signs and symptoms. So for example, if somebody has a predisposition to a thyroid condition, so underactive thyroid most commonly is because of an autoimmune condition where the antibodies are being produced against the thyroid, which doesn't help it to function properly. And any environmental trigger, like viral infection, any stress, certain medications can trigger it. So that's how, those are the things that would cause that to happen.
Mm-hmm. So a large number of the questions that we got were obviously about diabetes. So we're just going to focus on those questions for a little bit.
Sure. Yes.
So a big question, just for the audience to know, no one asked this, but I think it's important to know. What's the difference between type 1, type 2, and gestational diabetes?
Sure. So type 2 in general would happen generally later on in life, and it is generally associated with weight gain, overweight, obesity. Type 1 happens earlier on in life, generally in children or in the early teenage years. And gestational diabetes is when there is, impaired glucose metabolism during pregnancy. In type 1 diabetes, the basic thing is that the pancreas is not producing enough insulin. So, patient, they need insulin. They cannot go without insulin. In type 2, the pancreas is not producing enough insulin. It is producing somewhat, and then there is also insulin resistance. So whenever we put on weight, there is insulin resistance shows up. So whatever the pancreas is producing, that insulin is not being absorbed or not, it's not working because of insulin resistance. So that's type 2 diabetes. And gestational diabetes is, when all these things happen during pregnancy. So, when the person is not pregnant, they are fine. But during pregnancy, if the numbers go up, then it is called gestational diabetes. And then after delivery, generally it resolves. But having gestational diabetes during delivery does predispose one to develop diabetes mellitus type 2 down the line. So it is important to be monitored.
So other than obesity, are there any like causes of type 2 diabetes, or is obesity the primary?
Yeah, so generally it is overweight and obesity. Then, of course, there is again, family history. And then there are certain medications like steroids. Some people are on steroids for different conditions, for lung condition, asthma, COPD, or for any other, rheumatological conditions. So steroids can also cause type 2 diabetes, and also history of transplant, because once somebody has any organ transplant, lung transplant, kidney transplant, they are on all the anti-rejection medicine, so that those medications also increase the risk of type 2 diabetes.
So someone actually asked, like, with the genetic risk, like, what can you do to manage or reduce it if you know that your parents or grandparents have had it?
So for type 2 diabetes, then I would, majority would be lifestyle modifications. So it would be healthy, making healthy choices, so basically exercise as allowed and tolerated. Walking 30 minutes, 5 days a week also would help. Losing weight. So generally, if someone is overweight or obese, we say even 7% weight loss prevents progression to diabetes by 58%. And cutting down the carbs, so less rice, pasta, or spaghetti, bread, potatoes. We have to cut down on the carbs. So those things is what we can do.
So what can we see when we see, like, what are some signs of like pre-diabetes?
So pre-diabetes generally would not have any signs per se. Some people may have neuropathy symptoms, which is tingling, numbness, burning sensation, or pain in their feet. But otherwise, no pre-diabetes per se does not have any symptoms. It's generally picked up on routine blood work when they go for annual physical.
So when you bring up the feet, that like brings me to a good point. So like when I shadowed you, you always referred patients to either like an eye doctor or a foot doctor. And now thanks to you, I know why. But can you like tell the audience like the relationship between diabetes, the eyes, and the feet?
So diabetes, why do we want the blood sugars to be under control? Or why? Because it causes cellular damage. So there are people who have diabetes and they feel fine. They have no symptoms at all. And then, so many people tell me, why do I need to be on insulin? Why do I need to do this? I feel fine. I don't have any symptoms. But I always tell them, you're feeling fine now, but the high blood sugar is causing cellular damage. It is causing damage at cellular level. So high blood sugar, it affects the muscles. It can affect the nerves in the feet and the fingertips. So it causes neuropathy. Then it affects the vessels in the eyes and it causes retinopathy. It affects the kidneys, can affect the heart. So these are all the complications of diabetes. So generally, whenever someone has diabetes, we do tell them to, see the foot doctor regularly, because they may have neuropathy. They may have no sensation or altered sensations on the sole of their feet. And they may not even know it until it is checked or examined. So that's why the podiatrist is good, because, I always tell them, always check your feet before you go to bed. Sometimes if they don't feel their feet and if it is numb, they may step on something, not even know that they have stepped on it. And there might be, a lesion which can develop into an ulcer. So those are the things that we have seen. And so that's the reason why we refer them.
So clearly, like you said, like the effects of diabetes are so widespread. So obviously it'll have like a psychological impact on the patient as well. Like even in your practice, I remember seeing this one patient, he was like an ice cream man, but then he had to quit his job. Do you have any other like such experiences, like a memorable patient?
So I think, the person that you're referring to, I actually just saw him the other day, and, he's doing much better. His blood sugars are all well controlled now, and he feels healthier. He has much more energy level with that. So, so that's referring to that patient. Some other patients. So I had one patient who was just diagnosed with diabetes, and his, we generally check the hemoglobin A1C. And when we checked it, it was like 11.5, which is very, very high. It should ideally be, less than 5.7. So, and I was like, okay, so, because with this high hemoglobin A1C, you need to be on insulin and so forth. But he was just not ready to do that. And, upon asking, like, what happened? What have you been doing? What have you been eating? He's like, no, I've not changed anything. I'm not eating anything different. And then finally, after probing more and more, he said he had been drinking a lot of iced tea for the last few months. And he stopped that. And then when I saw him back in 3 months, his A1C was back down to 6.5. So without any medications, just with dietary modifications, he could do it. So things can happen, and if there is motivation, they are able to do it.
Mhm.
Yeah.
And for those of you that don't know, an A1C is basically like the average blood sugar level for 3 months, correct?
Yes, yes. Mhm.
So one person also said that they've seen like a lot of videos on social media saying like diabetes could be reversed. Is there any truth to these claims? Kind of like
Well,
what you.
so, we were always taught that diabetes cannot be reversed. It can be controlled. So when we say control is that we get the A1C to less than 7 or 6.5, then it is under control. Now, if people undergo gastric bypass surgery, gastric sleeve surgery, so then, most of the patients are able to get off all the medicines, insulin, etc. And that's how they talk about it is reversed. But in my practice and in my, experience, yes, it does happen. I'm not saying, I've been able to take people off insulin once they have the gastric sleeve surgery, bypass surgery. But after a few years, they do need help. It comes back. So because then, sometimes people put on the weight, or for, the underlying reasons, people do need, again, help, and the A1C creeps up. So generally we can keep it under control, but so far we cannot cure it or reverse it for, technical purposes. Yeah.
So, what are some like latest advancements that you've seen in terms of like diabetes management or treatment?
There's a lot of advancement, actually. From the time I was, under training, there were just, some oral medicines and insulin, and that's it. But now there are a lot of oral medications, which are good, which can help with weight loss, and they also have cardiovascular safety data. So all this is, useful for the patient, because most of the times diabetes is tied with high blood pressure, high cholesterol, heart disease, stroke. So having these medicines on board, which, has good effects on the cardiovascular health, is important. And then we have these other injections, which you must have heard, something called as Ozempic, Victoza, Monjaro. These are all injections which help with blood sugar control and can also help with weight loss, which is also very necessary, generally in patients with diabetes.
So kind of coming to the topic of like obesity and weight loss, like a lot of people ask questions about that too. So how do hormonal factors like contribute to obesity?
So from the endocrine standpoint, first and foremost, if there is underactive thyroid, that can cause weight gain and obesity, and if it is not under control, or if there is excessive production of cortisol, which is called Cushing syndrome, that can cause weight gain and obesity. So once those factors are ruled out, and then there is always, a genetic predisposition, and then environmental factors, which is affecting the growth, the weight gain. And so now we have, medications for weight loss. So there are some oral medicines, and then there are the injections. The oral medicines, they are also good, but then they do have a lot of psychiatric and cardiovascular side effects. So, that is only useful in certain group of people. But then there are injections, which are now, you must have heard, there are some of them are called Wegovy, which is once a week injection, Zepbound, which is once a week injection, and then there's something else called as Saxenda, which is a daily injections. And most people have had good weight loss with that, at least 20 to 30 pounds minimum. I mean, yes, they come with their side effects, and we have to be careful before prescribing. We have to make sure they don't have certain, but risk factors. But otherwise, they are good.
So that actually brings me to like something that's been on the news a lot recently, like Ozempic, and kind of similar medications as well. So who can and can't use Ozempic, and like what makes it good for both diabetes and weight loss?
So Ozempic and Wegovy. So Ozempic is FDA approved to be used in patients with type 2 diabetes, and Wegovy is the same thing as the Ozempic, but it is FDA approved to be used in patients with obesity mainly, but the ingredient is the same. So there are some FDA box warning that if someone has, these are rare conditions, but if someone has something called as medullary thyroid cancer or multiple endocrine neoplasia, which is multiple endocrine tumors of the body, we cannot use it in those people. So we have to make sure that the patient doesn't have that. Then these medicines, they have some side effects. So if patients have some risk factors for those conditions, then we have to be careful. Like if someone has pancreatitis, then we have to be cautious because it has not been studied in patients with pancreatitis, because these medicines, one of the rare side effect is pancreatitis, which is inflammation of the pancreas. Then there are some other, side effects about um, intestinal obstruction with these medicines. So we have to be careful. We'll have to look at their medical history, etc., and go from there, basically.
So a lot of people also ask, like, what's the best type of physical activity for losing weight, especially considering that obesity is like causes many of these issues.
Right. So, I always say that physical activity helps the person to maintain the weight loss. Physical activity by itself does not cause that much weight loss. So there has to be first the diet component, there has to be calorie and carb restrictions. That initiates the weight loss. And then exercise helps to maintain it. That is what I would say. So aerobic exercises would be the way to go.
Got it. So in terms of like kind of going back to diabetes, so there's like the ketoacidosis and like when you get like odd smelling like odor from your mouth. Can you kind of explain to people what that is and what that could be a sign of?
So when the blood, so generally diabetic ketoacidosis generally happens in patients who have type 1 diabetes, where the blood sugars are running very high, 300s, 400s. And, the symptoms are nausea, vomiting, belly pain, and they have this ketonic fruity odor. And they're just not feeling well. And it needs a hospital admission and they need to be on IV insulin to bring these numbers down and back in range. Generally, it happens when either patients they're not compliant with insulin, or anything triggers it, like any infection. So any infection can cause blood sugars to go up. And sometimes, and if they are not able to compensate by adjusting the insulin, then that can trigger them into diabetic ketoacidosis. So that's pretty much, those are the symptoms and how they pick it up.
Mm-hmm. So how would different patients present like with low blood glucose or like high blood glucose? Like how would the two different patients present?
So high blood sugars, mostly patients have, the common symptoms, as I said, is, feeling very thirsty, feeling hungry, and peeing a lot, and unintentional weight loss. That would be the, symptoms of very high blood sugars. Some patients may have no symptoms at all. That may be just, they just find out on routine blood work with their primary care physician. Then as far as low blood sugar, so low blood sugars, people will have symptoms. A low blood sugar is a sugar when the sugar is less than 70. And the symptoms are racing of the heart, sweating, tremors, feeling anxious, on the edge, or, just not feeling like yourself. So those would be the symptoms of low blood sugars. In fact, sometimes before a patient is diagnosed with diabetes, people may have the symptoms of low blood sugars, and they have to eat something. But on the blood work, they may just have either pre-diabetes or a little bit high fasting blood sugars. But this is a sign that they may develop diabetes down the line because the body is not metabolizing the sugar properly. So those are some little things that can happen.
Mm-hmm. Got it. So we also had a lot of questions about thyroid disorder, so kind of pivoting to that. Can you talk about like the hyperthyroidism versus hypothyroidism and the differences between the two?
So hypo is underactive thyroid. So common symptoms are weight gain, difficulty losing weight, constipation, feeling cold, dry skin, nail and hair changes, and low energy level. So these are the common symptoms of underactive thyroid. And the most common reason for underactive thyroid is something called as Hashimoto's thyroid disease. It's just a fancy name because of the person who diagnosed it, but it's an autoimmune condition affecting the thyroid, causing underactive thyroid. Overactive thyroid is, there are different reasons. The other common reason is called as Graves' disease. Again, there are antibodies that the thyroid that act against the thyroid and causes overproduction of thyroid hormones. Sometimes there are nodules on the thyroid gland which could overproduce thyroid hormone. There is also a condition called as thyroiditis, which is transient, that can happen after a viral infection, where patients can overproduce thyroid hormone and then they either become normal or they become underactive. So overactive thyroid symptoms are, some people have a lot of energy. They feel very hyper, on the edge. There is increased sweating or they feel hot when everybody else is feeling fine, unintentional weight loss, racing of the heart. Like the most common symptom is, with little activity, they feel tired, they feel short of breath, or they feel that their heart is racing. Tremors, loose stools. So these are some of the symptoms of overactive thyroid.
So you mentioned kind of like the autoimmune like disorders too. How does that play into like your role as an endocrinologist?
The thyroid, basically, under or overactive thyroid, the most common reason is autoimmune condition. So that's the thyroid is the only one in our field where the autoimmune condition would play a role. There are some rare, conditions where the pituitary gland also may be associated with autoimmune conditions, but mostly it is the thyroid.
Got it.
And then type 1 diabetes is an autoimmune condition.
Got it. Thank you. So we also have a specific question. Someone asked, how long can thyroid medication be continued for, and how often is a checkup needed for thyroid patients?
So thyroid medicines for underactive thyroid, generally it is lifelong, and it is one of the benign medicines to take, actually. Even in pregnancy, we continue it. In fact, we have to monitor the thyroid more closely during pregnancy because of the changes that can happen. And what was the other question? I'm sorry. How often?
Yeah.
Yes. So generally, when we make a change to a thyroid dose, we repeat the blood work in 6 to 8 weeks because that much time is needed for the change to show up on the blood work. Once the numbers are under control and patient is stable on that dose, then every 6 months. And, if they're stable for a long time, we can even do it once a year, but generally every 6 months at least.
Got it. Okay. So with those, like, can you like talk about some of the medications like that you mentioned, like that you would give to a thyroid patient?
So there is the most common one is called Synthroid. That's the brand medication that is commonly used. Then there is levothyroxine, which is the generic form of the medicine. Now, both of them are they're fine, they're equally same, but the American Thyroid Association, does feel that the Synthroid, the brand medication, sometimes works better in some group of people. But that being said, my take on that is if you're doing well on the generic, then you just continue with the generic. No need to change, especially if the insurance does not cover it. But if somebody is planning pregnancy or somebody has thyroid cancer, and if it is possible for them to go with the brand medicine, we do recommend using the brand because these medicines have something called as a narrow therapeutic index, which means even tiny doses in the ingredients can affect the levels of the thyroid. So, and then there are other forms of thyroid medicine like Unithroid, Levoxyl. These are all other brand medicines for the thyroid. Then, I do get some patients asking about natural thyroid hormone replacement, but we do not recommend the use of natural thyroid hormones.
So you talked about like specific groups of people being more inclined to certain things. So how does that work with like diabetes, obesity, and like thyroid disorders? Like what populations, I guess I should say, are like more inclined to get diabetes or obesity or thyroid?
So I guess for diabetes, if there is a family history of type 1 or type 2 diabetes, that would be one thing. If someone is overweight or obese, that would be another group of people who would be predisposed to diabetes. And then if they have other conditions where there is need for use of steroids on a regular basis or history of transplant, then those people would also be at risk for diabetes. Also, patients who've had multiple episodes of pancreatitis or pancreas surgeries. Pancreas is the one that produces insulin. So if that's not working fine, then that can also cause diabetes.
So sorry, I think I like worded my question a little bit wrong. I was meaning more like the race or like the race of people that are more inclined to get like diabetes. Like, do you see like a change between like, I don't know, people that might live Western, Eastern, like, is there any effect in that diabetes?
So actually, no. I mean, even in Asia, there are a lot of people with diabetes. In fact, I would say in India is probably one of the number one countries with diabetes because one thing is overweight and obesity, but in people who are not even overweight, there is a lot of visceral fat, like fatty liver, that itself can cause diabetes and can cause impaired insulin resistance. So no specific, in my practice, I haven't seen anything, anything to differentiate per se. No.
So can you talk about that visceral fat a little bit more? What role does that play?
So, I have a lot of patients, patients who are not that overweight or obese, and they do not have any antibodies for type 1 diabetes, but they have diabetes, they have high blood sugars. And the thing is that probably they have some fat depositions in the internal organs, and mainly it is the liver. And liver is also one of the main organs that helps with glucose metabolism. So when there is fatty liver, and that's commonly seen where the liver enzymes are high, and and that's where we talk about the visceral fat, and that can predispose to diabetes.
Got it. Kind of going back to hypothyroidism, I had a question about, someone asked a question about that. So someone asked, is hypothyroidism like reversible? Like if someone's taking medications, and the labs are within range, will the condition return if they stop taking the medication?
For underactive thyroid, hypothyroidism, generally not, especially if they have positive antibodies. Then mostly if we stop taking the medicines, the numbers will go back to hypothyroid range. Now, yes, there are some people who flip back and forth between over and underactive thyroid, and we have to adjust the medicines. But generally, unless it is a thyroiditis condition where there is inflammation of the thyroid, and then somebody has developed underactive, then it may become back to normal. But that's rare.
So when I was shadowing under you, I know that whenever you see a patient, you always talk about their calcium or like vitamin D levels. Like, can you talk a little bit more about that and its significance?
So the other thing endocrine will deal with is osteoporosis or weak bones. And that's where the calcium and the vitamin D level comes into play. So whenever someone has osteopenia, which is a step before full-blown osteoporosis, we do recommend that calcium and vitamin D is important to keep the bone strength or maintain the bone strength. So generally in postmenopausal women, we recommend at least 1,200 milligrams of calcium from diet and supplements combined to be taken on daily. So for example, if somebody has one full glass of milk, then that gives you about 500 milligrams of calcium. So then they can just take a 600 milligram tablet. So that gives them their daily, and then plus, you get some calcium in your vegetables, fruits, etc. So that gives them their daily intake of calcium. Then vitamin D is also needed for the bone strength. And, most of us are deficient in vitamin D because we are not exposed to sun. And so vitamin D3 is what we check, and we want the level to be optimal at least 30. And so most of us should be taking 1,000 IUs of vitamin D on a regular basis.
So we actually had a question coming like similar to talking about fractures. So someone asked like, if there's an overdose of thyroid medication, will it affect bones and will it make patients more prone to fractures?
Yes. So too much thyroid hormone replacement affects the bone density and can cause weak bones. Absolutely. Yes. So we don't want to do that. Yes.
So when you talk about kind of hormone replacement, I've heard of like people that have taken like growth hormone like injections. Does that fall into your practice, or is that
yes? So I do not know. So basically the growth hormone, the only time from the endocrine standpoint growth hormone is prescribed is generally in the pediatric population when there is a growth hormone deficiency. In adults, growth hormone treatment has not had many benefits. So we generally do not prescribe growth hormone in adults per se. Now, people may be using growth hormone as a supplement. That is a whole different story, but we do not prescribe that. But in pediatrics, there is growth hormone replacement if they have a deficiency because it's needed for their growth, basically. Yes.
Got it. Okay. And how do you know if someone's like deficient in that? Because if it's a pediatric, they're going to be smaller, like generally speaking.
No, so if they're not growing so properly, they have not achieved their height, weight, and puberty. So that's how they will find out. And then after that, more specialized testings are done to see what is going on.
So kind of going into pediatric endocrinology a little bit. So how do the hormones play into like puberty for both like males and females?
So that would be, mainly it would be the estrogen and the progesterone and the testosterone levels that, will rise, causing the changes to happen. Those would be the ones for the puberty. But then at the same time, even thyroid hormone is important for regular growth. So there are some patients who may be deficient in thyroid hormone and they may not grow. So, the pediatrician will check that. And if they're underactive, that's what mainly will cause the growth restriction.
So kind of going like kind of more into that. So I've heard of like conditions like PCOS or PCOD, I believe. How does can you kind of elaborate on that?
Sure. So PCOS is polycystic ovarian syndrome. That is a condition where someone has irregular menstrual periods, and it is generally associated with weight gain and other symptoms such as acne or excessive facial hair growth, or excessive hair growth. These are the common symptoms of that condition. Sometimes people may not have all the symptoms. They may have only one, like irregular periods and weight gain. But on blood draw or on blood work, it may show that some of the hormones are high. Sometimes people can have some variants of the PCOS where they do not have the weight gain, they are not overweight, but they have acne, they have excessive hair growth, and they have irregular periods. Then the other important part of this is they may have cyst on the ovaries. So this whole condition together is called PCOS. And having PCOS is an increased risk for diabetes and high blood pressure and high cholesterol down the line. So it is important that it is monitored regularly from the get-go.
I've heard of something of PCOD. Is that
The same thing, yes.
Oh, okay.
It's polycystic ovarian disease or polycystic ovarian syndrome.
Got it. Okay. And then kind of following through with like the female health, you talked a lot about like pregnancy and the issues that could come up during pregnancy in terms of endocrine. So can you talk about that? Like what should people be looking out for if they're about to get pregnant or pregnant?
So for pregnancy, in general, if there is no risk factor for any thyroid condition or they do not have any other autoimmune conditions, then nothing per se to look for. But if there is a risk, if there is a history of thyroid disorder in the family, then I would recommend that at least a TSH and the thyroid antibodies are checked, because sometimes having positive antibodies and a high TSH value above a certain level can predispose to, miscarriage, early preterm labor, etc. Yeah, that is what basically I would recommend. Yep.
So with the patients with like hyperthyroidism or like thyroid disorders, is it genetically passed down to children?
Yes, it can be.
Okay.
Yes.
Got it. And then so kind of going back to the pregnancy, I mean not pregnancy specifically. So what are the groups of people that are usually like they should see an endocrinologist even if they may not have the issues right now, do you think?
So family history of diabetes, especially type 1 diabetes, family history of thyroid conditions. So I would first, have basic blood work done by the primary care physician. And if they see that the thyroid levels are a little bit off, but not that off, or they keep fluctuating, then it would be a good idea for them to see an endocrinologist to see if they need any treatment, especially if they're planning pregnancy. And then for the same thing with the, pre-diabetes, that would be, if the numbers are running high despite of lifestyle modifications, then that would be the way to, see an endocrinologist as well.
So what? Oh, sorry, go on.
No, I was just saying that the other thing is, and on routine blood work, sometimes the calcium level comes out to be high. So that would be the another reason why someone would see an endocrinologist.
So when I was under your practice, you often talked about like spilling of proteins in the urine. Can you elaborate on that and what you're actually looking for
that's
there?
that's one of the complications of uncontrolled blood sugars. The first thing is, it damages the kidney. So, it's not going to immediately cause high creatinine level, which is the renal function level. It goes slowly. So the cellular damage, the first thing that we see is spilling of proteins in the urine. And so if we see that, we have to tell them that you have to get the numbers under control. If this is not controlled, it can get worse. And there are some medicines that we can use to help, progress that further and reverse that. That is, those are that they also have with blood pressure as well. So generally, when I see patients who have spilling of proteins in the urine, we start them on these medications. And again, based on their history, we may recommend to see to see a nephrologist or not, a kidney doctor or not.
So obviously, like, what do you do with patients when they have like multiple of these issues? Like they have a thyroid and a obesity issue. Like, what would you do with patients like that?
So for thyroid, based on if they have under or overactive thyroid, we treat that. For obesity, first we offer dietary counseling, meeting with the dietitian, etc. And if they meet the criteria for any of the weight loss injections, and if they're interested, then we offer that to them as well.
So sorry, but so what's like how, like, you being an endocrinologist, like, have you changed your lifestyle in any way because of that? And like, if so, like, how have you?
Yes, so basically, main thing would be the diet. Especially after seeing so many patients, with diabetes, I've been very careful with the carb intake, and then exercise. So trying to find time and exercising, going for walks, or at least having some kind of activity incorporated in our daily lives. Mhm.
So when it comes to the diet, like a lot of people ask, like, what should we consume more of? I know you talked about like consuming less of carbs, but is there anything that we should be consuming more of in terms of diet?
So I would say, basically fruits, vegetables, unprocessed food, whatever is fresh is what we want to consume. And then we have to pay importance to portion sizes. So I'm not saying stop eating the carbs. We all need carbs. It is important for us to have carbs, but in portion size, we have to control the portion size. That's the issue. So yeah, so basically fresh fruits, vegetables, and avoid mainly processed foods. That would be I would recommend doing that.
So we talked about like the role of like diet and like exercise. So can stress, because I know that you talked about like cortisol and like that, what effect does like stress play in like endocrinological health?
Yes, so stress can affect directly, indirectly everything. So patients with diabetes, if they're under a lot of stress, that can affect their blood sugars. The blood sugars can go up during that time period. Even pain can cause the sugars to go up. Stress can also trigger the underactive thyroid and overactive thyroid conditions, especially if it is a very stressful situation. So those are the two main things that how stress may affect the endocrine glands per se.
So I actually had a question come in. Someone asked, like, if a patient is having like hypothyroidism and it's like weight loss is really difficult, even with like 60 minutes of exercise, is there anything that they could do with just their diet without like, because the exercise isn't doing much for them? Is there anything that they could do with just their diet?
So with make sure that the thyroid medicine is optimized. There are sometimes some thyroid experts believe that the TSH level has to be at a certain number, like less than 2 or less than 3, less than 3 generally. So if there are some patients who have some symptoms, so I try to keep their TSH to less than 3 if they're able to tolerate it. So we have to do that first. Secondly, as far as diet and thyroid, we do not recommend any dietary changes with any thyroid problems. We do recommend, avoid too much of any raw cauliflower, raw broccoli. Everything in proportion is okay. But I have had some patients who have tried gluten-free diet, who have underactive thyroid and have tried to be gluten-free, and they've had some success with weight loss. So the thought is that, gluten sensitivity is an autoimmune condition, and thyroid is also an autoimmune condition. So maybe there is some connection there, and that's how people are having that benefit of weight loss with being gluten free.
So kind of like what we talked about with the diet and all, is it possible, do you think, to manage these like hormonal imbalances or anything else without the use of medication, just through diet and
So generally not. I mean, if someone has underactive thyroid and if the thyroid levels are high, then I would recommend using the Synthroid or synthetic thyroid hormone to manage it. Dietary modification per se by itself, it may help for a couple of months, but I don't think it would help in the long run.
So patients that don't have these issues, how often should they get their hormone levels checked out?
Then they don't have to get their hormone levels checked. In their routine physical, generally they check a TSH level. They don't check the whole panel, but they check the TSH level once a year, and that's good enough.
Okay. So kind of like, what are some like general tests that you do? Like, I know you do blood tests. Like, can you talk about those that you do to diagnose the endocrine disorders?
So depends on the patient's symptoms, because if I were to test all the hormones, there's a good chance something will show up, because all these hormones have diurnal variations, which means they are high in the morning, low at certain time, and there are different things like medications, the foods that we eat, the day-to-day stress can also affect these levels, because these are all hormones. So generally I will check the hormones based on their symptoms and their complaints.
So, with like endocrinology as a whole, like, are you able to like tailor like medication or like treatment plans for each patient, is it like dependent on the patient, or is it more just like, okay, if they meet these set of requirements and they're going to get this medication at this dose?
No, so for thyroid, it is, if they have underactive thyroid, then they have to take the thyroid medicine, because it has to supplement the thyroid. If they're overactive thyroid, then we have to put them on a medicine to control that. And then there are some other treatment options, but that is if the medicine does not work. For diabetes, since there are so many treatment options available, we obviously go by their medical history, their kidney function, their family history, and then we decide which medication would suit them the best.
So if you're like taking those tests and you have like condition like hypothyroidism or such, and during your blood test, like the values they're like within control, how often do you have to like visit the doctor and do like?
Then every 6 months. So generally every 6 months, unless someone is in the reproductive age group and then they find out they're pregnant, then in that case, we recommend checking the thyroid every 4 weeks.
So obviously, like in your profession, like education is very important to manage such health conditions because the patients have to know what's going wrong, like what's wrong with them. So how are you able to how do you try to educate your patients in your practice? I guess I should.
So for diabetes, we obviously, when they are diagnosed, we go over everything about the dietary modifications and, what are their blood sugar targets and what are the symptoms of high blood sugar, low blood sugars, and what they have, as you said, I tell them to see the eye doctor, the foot doctor, those basic things. And then every time when they visit me, I remind them of certain points as well. We also recommend them seeing a dietitian for a more detailed information about the diets and counting the carbs, etc.
So kind of going back to when we talked about women, I had a question come in. So what should people be looking at like after like the postmenstrual,
like in menopause?
Yeah, in menopause.
Yeah, so I would say mainly mainly the bone health. That would be the number one thing to do. Have a bone density study, the DEXA scan, to see is it in the osteopenia range, osteoporosis range, check their vitamin D level. I would also make sure check the thyroid levels, because sometimes menopause can also trigger certain changes. And then I would get a hemoglobin A1C, which is a 3-month average of the blood sugar, a fasting blood sugar to be checked, cholesterol to be checked, calcium levels to be checked. So those basic blood work I would do, and a bone density study.
So what have you seen is like the psychological impact on the patients with such like chronic disorders?
So, thyroid people are, I think I've had people are more receptive to the medications and so forth. With diabetes, it is tough. It is a lifelong process. They have to check their blood sugars. They have to make, dietary changes. Some people have to check their blood sugars before every meal, and based on their blood sugars, they have to dose the amount of insulin, etc. So it is, they have to accept the diagnosis, and then they have to find time to incorporate these things in their schedule. So it is tough, but nowadays there are continuous glucose monitoring systems, so that monitors the blood sugar on its own. They don't need to do a finger stick, so that's convenient, so that's helpful nowadays. Yes, so there are a group of people who they don't come to terms with the diagnosis, and they refuse treatment, and it is tough. It is tough.
So you talked about the continuous glucose monitor. So how can like technology like those and like insulin pumps, like how have they like affected kind of the industry?
Oh, it is actually very good, especially the Freestyle Libre. You must have seen the ads. It is a continuous glucose monitoring system. The people wear the little device on their arm. It used to be changed every 14 days. Now they have come up with every 15 days. And the reading directly goes to their phone. And actually, you can also link up with family members, and even the family members will receive the readings on their phone. So, if like, for example, if my mom is wearing the Freestyle Libre, she has it on her phone and she can see the reading every single second. And I can see the reading on my phone if I have connected it to her. So even if she is away, like if she's in India, I can still see the readings on my phone because she's in. So it's a very good technology. Yes, it has the pros and the cons. It's not very accurate. but it gives you a trend. If the sugar is going high, low, it gives you an idea. It beeps if the sugar is too low, it beeps if the sugar is too high. So it is very good. And then the insulin pump, nowadays the insulin pump is integrated with the continuous glucose monitoring system. It's called a hybrid technology. So what that means is, based on the blood sugar, the pump will deliver that much amount of insulin. So it works like our pancreas. Basically our pancreas produces insulin based on the body's blood sugar. So these pumps with the continuous glucose monitoring system, they deliver insulin based upon the patient's blood sugar, and they adjust it based on the blood sugars. So it has helped a lot of patients with that.
So I remember when I was coming in, there was like patients that were just unwilling to like use like needles or like inject anything into their body. So what do you do for when you come across patients like
so we have to be patient, I have to explain to them, especially nowadays, it's no longer the syringes and the big needles. They have pens, and the needles are very small. So we can show them that it comes like it's in a pen form. The needle is very small. You may not even feel it. And so we have to convince them that it is important, and you should do it. So they may not be willing in the first visit, and then maybe next visit they may be able to do it. So sometimes you kind of prep them that if this doesn't work, then you may need to go on insulin, so that they are mentally ready next time when they see you.
So we actually had a question come in asking about like intermittent fasting. Have you seen that has any effect on diabetes or?
Yes, so so there are mixed views about intermittent fasting. Previously, it was pretty much beneficial, they said. Now they have some pros and cons to it. With diabetes, it is tough because if they're not eating and if they're on insulin, then that can cause low blood sugars. So I do not recommend my patients to do intermittent fasting. If they are doing it, I just counsel them, advise them to be careful, but I do not recommend per se. My recommendation is, whatever diet you follow, you have to follow a diet which you are able to stick to. Because some people will follow a very vigorous diet, and then, they will do that for 2 or 3 weeks, they will lose some weight, but then they cannot sustain it. So then it's no point. So I feel that just, follow a diet which you're able to sustain.
Mm-hmm.
So that
So,
would be.
yeah. So talking about like diets and exercise a lot, clearly our lifestyles have changed a lot. So kind of from the time that you started, like when you've entered this field to now, like what are like the major changes you've seen, especially considering like our changing lifestyles today?
In relation to
Like
diet?
endocrinology, like have you seen like an influx of patients like in
Oh yes,
certain?
lot of more patients with diabetes, lot of more patients with thyroid conditions. Especially in the last few years, we have seen a lot of patients with over and underactive thyroid. Certain viral infections have triggered it, and so forth. So yes, absolutely.
So you said that viral infections could trigger it. Could you talk about that a little bit?
Yeah, so as I said, if there is a genetic predisposition to underactive thyroid or overactive thyroid, any stress or any viral infections will cause the thyroid to not function properly, and the patient can either become underactive thyroid or they can become overactive thyroid. So we had some patients, who developed, inflammation of the thyroid after COVID infections and so forth. So we have seen a lot of, thyroid cases after COVID infection as well.
Yeah, so kind of wrapping up the meeting, what do you look forward to in the future of endocrinology?
So I guess, we look forward to, having the integrated insulin pump system. First, the insulin pump was mainly for patients with type 1 diabetes, but now, patients with type 2 diabetes also benefit from it. And, integrated with the continuous glucose monitoring system, it makes it very convenient. And the simpler the technology it is, the more people will be able to use it. And more importantly, I hope that the insurance, covers it, because we have a lot of fight with insurance, because mostly the insurance doesn't cover half the things, and it becomes very difficult. People, even if they need it, they don't get it. So I hope that changes. So yeah, that is what I would be looking forward to.
So with like an increasing role of like genetic like testing and like genome mapping, how do you see that, and do you think that it could help in your field?
So in our field, I would say the only test, right now they have come up with is patients who are predisposed to type 1 diabetes. There are some antibody testing that can be done. And if they are positive, then there are certain medications that can be used, which can prolong the time when they can start using insulin. So it buys them like 4 years before they can be on insulin. That is the only thing that we have used, we have seen so far in our field.
And finally, what's one message that you think you would like to say to all like aspiring doctors out there or anyone that wants to come into endocrinology?
Also, it's a very nice field, endocrine. It controls almost all organ systems in the body, and to diagnose overactive, underactive thyroid, calcium disorders, bone disorders, pituitary gland disorders, it is challenging at times, and you have different types of people, and you have to cater to their needs and counsel them. So it is a very nice field, and it is sometimes it is not not too many interventions with the field. So if someone does not want to do any too much intervention, then that would be also a good field to take. But diabetes is on the rise, thyroid conditions are on the rise. So there are a lot of endocrinologists. We need a lot of endocrinologists. The wait time is 6 months, so it is tough.
Okay, yeah, thank you so much. So with that, we're going to be concluding our meeting today. Thank you so much, Dr. Chiniwala, for finding the time in your busy schedule. And thank you so much for such an informative session. Also, thank you so much for everyone attending this meeting. If you missed any parts of it, I will put a recording of the meeting on my website by tomorrow. You can see the website linked in the Google chat. We will also be having another meeting soon in around 2 weeks about emergency medicine from an EMT. So I hope you all will be able to join that as well. Thank you so much, everyone, and have a great rest of the day. Thank you, Dr. Chiniwala.
Thank you, Priyanka. Thank you. Have a good evening. Bye-bye.